Thank you very much. Steve, next on the hit parade, community mental health.
Yeah, I'll just do a very brief overview. Very complicated fund. John Kinch and some of his folks are here. We'll be able to discuss it in much more detail. You'll see the budget is going down about $17 million. I think, it's Medicaid cuts particularly. There's a large decrease in supplies and services, which I think John that's all tied in with the Medicaid revenues and the cuts in those things. And that's really what's going on here. I don't think they have any new position requests. The general fund contribution actually is going down about $56,000. That's been pretty consistent the last few years, around $4 million. It's about 3.994 for 2018. But really the guts of the program are Medicaid cuts is I'm sure Mr. Kinch will address.
All right, thank you, Steve. Good afternoon, Mr. Kinch.
Good afternoon.
You don't look happy.
Mr. Chairman, it's always nice to see you and the board here. My opportunity to be able to provide an overview of our budget, and before I do that, I have to thank you once again as being, having a governing role with community mental health, your voice, working with the Community Mental Health Board, with the legislature. We had a very difficult financial year last year. Serious challenges to being able to deliver consumers services, and I very much appreciate your voice and what you were able to do to help us out with some of our funding challenges. I think we're past the majority of that hardship. A little bit more to come, but certainly, far beyond where we were a year ago at this time. I provided two pretty hefty documents for your review. A little bit challenging for me to know where you're at on your electronic software there, but I did provide for you a state fiscal year validation of performance measures, and if it's all the same to you and if you really don't mind, I'm going to pass through that and just skip that for right now. It is an attribution of some of where Macomb County Community Mental Health as a PIHP stands relative to the success in our contracts, our compliance with the contracts with the state of Michigan, and if you peruse through that, I think you're going to see it's pretty much flawless. It also provides the number of statistics relative to the consumers that are served, but I also caution you too, when you look at that document, the statistics that you see in the consumers served, that is only Medicaid, and it is only for 1 quarter. So at large, we also have Healthy Michigan plan in there. We have general fund consumers that we provide services to, and then we also have the Medicaid population. So we're servicing about 14,000 people a year just in through supports and services. The document that I passed around, I'd like to go to that one first. I just passed around. It's part of the my strategic plan, and I've given you the entirety of the strategic plan. I'm going to give it to you before I give it to the Community Mental Health Board, and they're going to get it in a couple hours yet tonight. But the one document that has the circles and it's entitled Capitated Shared Risk Shared Savings Contract. I just passed it out. Everybody's got that. I think it's a good illustration for everyone to understand where the money comes from and what we're looking at relative to community mental health. We really have 7 large contracts that constitutes our business. On the left side, CMS is the Center for Medicaid and Medicaid Services, Medicare and Medicaid Services. That's the federal government, and they issue dollars. Those are Medicare Advantage plan dollars. They issue those dollars to those 5 integrated care organizations. They're listed across there, AmeriHealth and Health Alliance Plan. Those monies, they subcontract with Macomb Community Mental Health. We're part of that pilot demonstration region, a federal demonstration, and we get those Medicare and Medicaid dollars, and I'll run through the numbers for you really quick too, as part of the demonstration to our agency. Also on the right-hand side of that graph, you'll see CMS again, where the majority of all our Medicaid dollars, about $180 million of our Medicaid, flows through the CMS. It goes to the Department of Health and Human Services, and then obviously we're a downstream contractor with the Department of Health and Human Services. And then just below that too is the State General Fund. So not to take that off the table, we have $8.1 million in State General Fund. So we're Region 9, we're one of 10 in the state of Michigan. We're a standalone, as you understand that. So we're the PIHP, where we contract services out. We're also CMHSP, where we deliver services. I think that provides you a good overview of how community mental health is operated. If you go on to the strategic plan, and again, I'm at odds because I don't know what page to refer you to. Probably my fault that I didn't number them, huh? But there's the goals and the objectives in in my strategic plan. Can everybody find that?
Yes, page 155.
Okay, that'll make it. So on 155, the number one goal that we need to adhere to is compliance with the 1915 BC waiver program. It's also referred to the Healthy Michigan program, the Flint 1115 water waiver, and the substance abuse and community mental health grant programs. That all in itself is our Medicaid contract. So if you perform well enough the previous year, you get offered another contract to engage in business in your subsequent year. We spend about $9 million in administration of that Medicaid contract. So for me to sit here and try to describe for you the extensiveness of that contract, I just maybe I'll hand you the contract. It's lengthy. And so that is our Medicaid contract, and we continue to perform pretty well within that contract according to the state standards. So the number one goal, if you're going to be in business and you want to continue to be in business next year, you better adhere to your contract that you currently have in your hand in front of you. And so that's my number one goal, is to make sure all of my administrative staff adhere to the Medicaid contracts, all of the deliverables, the compliance regulations that are all within. The second goal there is the general fund contract. Let's not forget our indigent consumers. Many of those who've never got into Medicaid, they're indigent and they need health care as well too. We are the public safety net. The third goal there is the My Health Link demonstration. There's only a few of us in the state of Michigan that are doing this. It's a big deal. For absence of better words, I like using that word though. It's a big deal that we are engaged with those 5 integrated care organizations. We're integrating Medicare and Medicaid services together as part of a federal initiative. And then the fourth goal that I have there is compliance with the substance use disorder contract and all of the block grants that they have available to themselves as well too. You might want to make a side note that on October 30th, this coming October 30th, MISD at 6 o'clock, we're going to have a community forum addressing, at least speaking to some of the opioid crisis that's going on. And we're also going to review many of these contracts and these block grants, what they offer up. If you go to page 5, it's maintain financial solvency. That's the other thing. As much as you have the contract, how is it that we go about maintaining financial solvency? Probably many of the commissioners have received phone calls from constituents where their service has been cut. It's through an ongoing effort of utilization management, attention to the dollars. I've reduced a lot of staff. I've got about 60 vacancies. There's a number of things that we've done, try to correct for the shortcoming of revenue. We'll fix that though. So the Medicaid, first line is the 146 is Medicaid. Second line is about 18 million in Healthy Michigan plan. General fund is about 8 million. The collective, and these are all projective costs or projective allocations and what we expect in the way of cost. We want to be cost neutral at the end of the year. So Aetna, Molina, the Health Alliance Plan, Michigan Complete Care, and AmeriHealth, we pick up about $2 million there in that initiative. The remaining of all of those block grants are related to substance use prevention, treatment. And so we're going to continue to actively pursue dollars with the Community Mental Health Board through the legislature. As you all know, we got about $5 million last year thanks to our collective efforts of everybody, including the community and the consumers who were hurt and had a voice. My thanks to Commissioner Kraft as well, that we were able to get $5 million, in allocations from the Speaker of the House, and we're going to go after another $7.5 million to see if we can get that $12.5 million that we need. So we're going to continue to maintain financial solvency. If you turn to item number 6, goal number 6, better, greater, expanded care with the HMOs. Those are the 8 HMOs that are in the metro region, Detroit, Wayne, Oakland, and Macomb region, that are part of an initiative. We want to engage in yet another integrated care initiative. You're integrating behavioral health and physical health care. So that's a goal. Number 7, I'm really not going to speak to, but it's an important goal. Number 8, not necessarily something I want to speak to right now, but an important goal for us. Number 9, CMH authority. Many times I've been before this commission here, and people say, how come you aren't like them? How come Macomb County isn't like the other counties? There are 83 counties in the state of Michigan. There are 46 community mental health programs. Okay, we're one of 46 community mental health programs. 42 community mental health programs are authorities, and there's 4 that are not authority. 3 of them are a little tiny. I probably have more money in my pocket than they have in the way of a general fund budget. But we are not an authority. The Community Mental Health Board has never wanted to take up that position. The last time we did a comprehensive study on the pros and cons of a community mental health authority was in 1997. So all I'm saying in this proposal to the CMH board tonight is let's take a look and either hire a health management agency or a legal firm to do an analysis of what is the risk of inaction, of not becoming an authority, or the risk of action if you do become an authority. What does the future health place and the future marketplace look like? Do they want to contract with government, or do they want to contract with someone else who's non-government? So far, we've been pretty successful with that, but we have to ask that. What's in the best interest of the 140,000 people who are enrolled in Medicaid? So I think we do this comprehensive study. And I'm not suggesting I go to the board and say we need to become an authority. That's not what I'm saying at all. It takes a resolution by the Board of Commissioners. There'd be a lot of community education. I think that there's, I believe, minimally 3 public hearings that need to be had if we were going to go that direction. And it would take a year to become an authority, and everything would stay in place for another year. So I really, at this point in time, can honestly say, you know, is it in our best interest to be an authority? I don't know that. That's why I think we should conduct a study. And before I get my cart before my horse, I got to find out how much it's going to cost me for the study. Can I afford, you know, $80,000 right now for a study? Probably. Could I afford $480,000 right now? Probably not. So I don't have the construct for what I'm going to ask for the engagement firm to look at what I really want, because we would have to take over human resources. We'd have to take over legal. We'd have to pay our own checks. We'd be able to own property, those types of things. So I'm only going to go to the Community Mental Health Board. Now is the time, 20 years later, to do a risk analysis, pros and cons of authority, non-authority, and, you know, if we act, you know, the risk of acting and the risk of inacting. So now is just the time to do it one more time. And then the last thing, number 10 is My Health Link, the big deal. And then number 11, there's a lot we don't know about the future. You know, if anybody can sit here and tell us what the federal government and what President Trump has relative to Medicaid coming to Michigan, we don't know that. I'm pretty certain, though, or a lot of us may believe it's going to be block grant money. And if it's block grant money, the federal share of being able to carry any risk with our consumers is going to be gone. It's going to be born to the states, and everybody, it's going to be like a piece of Swiss cheese, because everybody's going to take their little knife and want a piece of that Medicaid money for us. And it's not going to be as much Medicaid dollars as we have now. I also know, or have reason to believe, well, let me move on to the second point there under number 11, is that the legislature has, you know, we all knew about the governor's budget a few years ago, 298, and the legislator wants these pilot programs to be trying to define the future. You know, that's just a slow train out of nowhere. That's going to take forever, so I'm just not even worried about that. But we don't know what that's going to offer up. I believe there's going to be considerable reductions based on future or previous gas tax initiatives that have occurred, where the state general fund is going to see about a $4.5 billion reduction of their $10 billion that's going to be redirected, as it has been already legislatively mandated, to roads and infrastructure. And so we don't get much Medicaid dollar or general fund dollar now. There will even be less general fund dollars. So we have to be very savvy on how we purchase services, and that we make sure that those services are triple aim. They have cost, quality, and outcome. And if they're not affordable, then we need to outsource them and see if someone else can purchase those services. If we can afford them and we're really good at providing them, those are where the community mental health programs, you know, stands to live a long life. I think we have 2 or 3 years to really sort some of this out. You know, I hate to always say it's about money, but it's always about money. And the consumers are very much in need of ongoing support. Their hardships are incredible. So I'm coming to the Board of Commissioners again here with the budget, and the thanks of Steve, that we need the $1.7 million in the required Medicaid match. That's in there, and that stays the same, $1.7 million in Medicaid match that comes from the county. The 2.2 in drawdown that, you know, has been relatively consistent from you along the way, and that number really hasn't gone one way or another. We also asked the county executive, and the board supported us last year for $2.8 or $287,000 to maintain the Macomb County Crisis Center It's not the Community Mental Health Crisis Center. It's our Macomb County Crisis Center. We took those monies last year. We hired 9 people. Phones were answered all the time. And then also another $264,000 for GF support because we took such a big GF cut. So in all of that, I think our budget is pretty much cost neutral, if not up, maybe $45,000. That's my overview. Thank you for giving me your time, and I'm going to invite my Chief Financial Officer, Cynthia Mack, up here. I've had 4 CFOs in 4 years, and Cynthia has weathered the storm for a year so far. So the budget is not easy. It's very complex, and I'm going to ask her to support me in any questions you may have. Thank you.
Thank you, John. Cynthia? Are there any questions? All right. Do we have a motion to receive and file? We have a motion to receive and file by Drollet, support by Kraft. Commissioner Leonetti.
Thank you, Mr. Chair. John, I just want to, I want to thank you. When you came back to see us in March, it seemed like it was a crisis that we were dealing with. And, I appreciate you thanking Commissioners Kraft and Toko and anybody else and Commissioner Duge that was involved and the rest of us. I think your hard efforts, being up in Lansing quite a bit and doing what you had to do so that we can maintain our independence was admirable, and I do really appreciate that. One question on the study for the authority. How much of a priority do you think that is for you? I mean, on your thing, you had it number 9 or 10. Sometimes I look at things like what's first, what's second. Do you think it's something that we should do here after 20 years of looking at it last time? Because one of the things I heard when we were in that crisis mode is that we might be able to save ourselves if we became an authority. And now that we're, kind of okay, is it something that we may have to look at if it comes to be a crisis again?
Well, it's a very interesting question, a great question, but it has a lot of different answers to it because, from the county perspective or from the office of the county executive and the board of commissioners, do you want larger government or smaller government?
Right.
Do you want $200 million flowing through your county purse? Does that affect your bond rating? All of those types of things I think would be taken into consideration. Is there greater value for us or for the consumers? What's going to be in the best interest of the consumers? And that's where we all need to be. Is it going to be better interest of the consumers to be an authority, and then the board of commissioners still, appoints a board before the authority, and then it's retained in Macomb County. Let's just hypothetically say that Molina gets, a larger share of the Medicaid dollars in the coming years, and Molina says, I really don't want to deal with county government, So I'm just going to ask Oakland County to take care of Oakland and Macomb counties together. That's a possibility.
Yeah.
Yeah. And so really it's the wishes of the board. I don't want to get ahead of the board because I'm not saying we should do that, but I think we need to be able to really have a comprehensive study. What is all the great value that, may offer or may not offer as a mental health authority, and then, what are the risks if we do or we don't. So
Yeah, I think I get what I get your answer, and I think it's something that, you say if it's an $80,000 study or a $400,000 study, I think you should get this study. Do you know what I mean? I think I get it. You're not saying we should do this or the other, but we should have an analysis. And I do believe in getting data, and I do believe in getting an analysis, so that way we're in a better position in case this happens again, that we can act quickly on what's in the best interest for the consumers, as you said.
So if I could put the engagement together, I don't believe I'm going to go through a formal RFP for it, other than ask for a consulting firm to give me bids on what it is I'm looking for, but I need to be pretty descriptive in what it is that I want them to do, so I can get fair bids across the board from everyone.
Thank you.
And then I would take it back to the board, saying, do you want to contract with an agent to do the engagement or not?
Okay. Thank you, John. Thank you again for what you've done. Appreciate it. Thank you, Mr. Commissioner. Or thank you, Mr. Chair.
You're welcome. Next up, we have Commissioner Toko.
Thank you, Mr. Chair. John, when you were here in March, there was a $12 million problem, and I understand that there was a $5 million fix. What happened to the other 7, and how does that affect the budget going forward? And how does that affect the issues of the risk corridor and the contract with the state?
That's it's a great question. And it gets really tricky, the answer, and I certainly don't want to put anybody off base or uncomfortable with it. the state recently allowed us to use Medicaid and Healthy Michigan funds and the savings from those funds and combine them, be able to use any savings from either one of those funds and combine them in our risk management strategy that we're gonna put together next month. However, you cannot use those dollars to protect yourself or to cover another fund. So we have $6.3 million in extra monies through Healthy Michigan. We can show that as far as our strategy, along with the $5 million that we got from the legislature as a holder, we can show that to be fully funded in our capitated risk plan, our capitated risk on October 1st, but we can't use those Healthy Michigan should we run into a Medicaid problem. But they let you do it that way. So it's kind of like, you can blend your dollars, but you can't use your dollars accordingly. So, and we've discussed this with the Community Mental Health Board. So there is a necessity to go after that other $7.5 million. So Cynthia has a balanced budget for next year, this year, and for, this year going into next year. But we need to pick up what is artificially inflated by the 6.3 in Healthy Michigan plan dollars. Say that right?
So what is the plan for doing that?
The plan for
I mean, how,
procuring the dollars,
yes.
I've been working with the Community Mental Health Board, and sometime within the next 3 weeks, what we will do is, I already wrote a letter to the Speaker of the House, Leonard, about the $12 million that we needed, and through the efforts of many of the Community Mental Health Board and the Board of Commissioners and some of our lobbyists, we got the $5 million. We've heard that verbally that Speaker Leonard said he would offer up another $7.5 million in this fiscal year, but it's a matter of working with the legislature, the Macomb delegates. And so what I'm going to do in short order here is put together a white paper with a cover letter back to a white paper with the hardship relative to some of the challenges and some of the human effect that's occurred here in Macomb County. I'm going to review that tomorrow morning with my Citizens Advisory Committee. I'll review it with the board tonight. I'll bring a white paper back to the board with another cover letter to Speaker Leonard, CC'd to the Macomb House and Senate delegation, asking for reconsideration or not reconsideration, a continuation of that $7.5 million. And they're in the session until the week before Christmas. So I would think along about the 1st of November, they'll get my letter. And at that point in time, I'll bring all the Macomb delegate up to speed too on the need for the dollars. And then we're also going to do a community blast that all of those families who have been affected, that we're going to ask them to start showing up at the coffee shops and wherever the House and Senate delegates are having their community coffee clutches and those types of things, to continue a voice and say, here's the face, here's how it hurt me.
Okay, thank you.
Okay, thank you. Question, the jail diversion program. We had 1.5 positions open, that was the request. It's not necessarily that this board turned it down, but executive didn't recommend it. Are you going to try to get that again, or is there any push to get that jail diversion program manned up?
I believe from what our understanding is currently and what we've heard of the possible changes out with jail diversion,
Yeah.
we're comfortable with the 1.5 at this point.
Okay, are you pushing it at the for the executive level?
I
Because
don't-
we didn't turn it down, the executive actually didn't recommend it.
I believe we'd want some additional internal conversations with how that program is going, and again, within the whole county. I think we've heard some different stories as far as what the direction is.
Right.
So in order for us to pursue it appropriately, we'd want to take that into consideration.
All right, fair enough. But, because my understanding is it's still not recommended by the executive. If it was up to me, then I'd love to do it, but we do have systems here.
Right.
Thank you. Any other comments or questions? Commissioner Carabelli?
Thank you, Mr. Chair. Quick question. The shortfall, or the $5 million you receive, is for what year?
It's a placeholder. They gave us state general fund dollars, and it's a placeholder to be thrown at Medicaid, not to be used, and it's for fiscal year 18. It'll be used as revenue for fiscal year 18, the coming fiscal year, as a placeholder to help us with our internal services fund.
And then the $7 million that you're short is for what area?
It would also be used for, see, the concept, if we can get those $7.5 million, then we will be able to maybe soften some of our utilization management practices. And that's where the legislature understands is that we have been so aggressive in utilization management and cutting services. If we get some added dollars, then we ought to be able to soften those.
So you're saying for 2018, not 17? You're saying you're fully funded for everything you got going on in 17? You're not amending the budget from what was originally proposed?
We're going to close out 16, 17, which is already gone, you know, we will know definitively. It takes about 5 months for us to close our books. So we don't need any more additional dollars for 17, but for 18, beginning the 1st of October here, we're still looking for that $7.5 million.
Okay. Above and beyond from what you're receiving from the general fund now, are you asking for any more county dollars, general fund dollars to assist in any of this, or is this just strictly you're going to the state?
Correct. It's only the county dollars we're asking about are just for the 264 on the GF that you gave us last year, county match, and then not match, county dollars, and then on the crisis center. So it's about 500, same 500,000. They're about the same as you gave us last year.
Okay.
Nothing more.
So your fiscal year 18 starts when?
Started 11 days ago, October 1st.
11 days ago. In 18, and then you're still $7 million short, and you're projected to continue the program with the hope that you're going to get that $7 million. Is that what I'm understanding?
Our budget is balanced, but we're still that money short. Yes.
Okay, and I apologize, maybe I just don't get it. So in 2018, which started 11 days ago, you're $7 million short of accomplishing the budget that you're, or,
It's the risk reserve. You know, that's why it's complicated.
Okay.
It's the internal services fund.
all
We
right,
go,
let me back up and ask this question. There was monies cut because we were doing a service a little bit different than the way the state wanted us to do the service, or the federal government wanted us to do the service, correct?
I wouldn't agree with that, no. I stand pretty convicted on the way we were doing it is the way we should have been doing
Let me
it.
rephrase the question. We are providing a service that they, not that you don't agree with,
Yeah.
that they don't agree with, and we were cut several $million, correct or incorrect?
I think the school's still all that. No, I'm not trying to be argumentative. The state has not come up with a definitive declaration that we've been doing it any different than anybody else.
Okay.
It was state average.
If everybody agreed that you've been doing it the right way all the way along, you wouldn't need to ask for the additional money, correct? So if they said, nope, here's all the money that we cut back because you're correct, we wouldn't have to go ask for the $5 and the $7 million?
I think there's a perception there based on the
Okay,
departments.
listen, all due respect,
Yeah.
well, no, I just want to talk about the part. If you were made whole by the service you were performing, that you explained to me the last time that they didn't agree, but you were going to argue and explain to them why you are correct. That amount of money that they didn't give us, is this the money that you're trying to get that extra $7 and $5 million?
A portion of it, you know, as you know, we lost a whole lot more than that over the period of 2.5 years. So it's a portion of it, yes.
What percentage would the dollars be if you had to quantify it? Out of 100%, would it be 90%, 80%?
The number I have on the top of my head, the number that will lose, Macomb County, CMH will lose in the way of Medicaid dollars, not Healthy Michigan, B3 state plan dollars, the majority of our dollars, from April 1st of 2016 through September 30th of 18, during that 2.5 year period, $37 million, 17%.
All right, thank you, Mr. Chair.
Thank you, Commissioner. We were going back and forth with that originally. Any other comments or questions? Commissioner Toko.
John, where are we at on the crisis center? Is it now at a break-even point financially, or how did last year shape up with that? Do you know yet?
Before, what we had done is we were going to try to turn that over to a voluntary service agency, or a voluntary, volunteers answering the phone. And in light of the fact that the general fund dollars are going to continue to go away, and everybody else has a call center, every HMO out there, Molina, they have their all call center, their own. They're not going to ask for us to provide a call center. It was the Community Mental Health Board's interest to preserve someone on the phone, and so the deficit, the 200, I'm just have to take a shot at it, about half of what it would take to run the crisis center, we're picking up through general fund dollars. The other half would be picked up through the contribution from the county. And I have to be pretty close with that, but I don't know the exact numbers. Though it's running, it's fully operational at this point in time. We have a live voice on there 24/7, 365.
Didn't, maybe some of the commissioners who were here a couple of years ago, didn't the board vote to put more money into the crisis center? Wasn't that a budget amendment that we did?
I don't remember.
Okay, that's something.
Is Smeagol
You
still
did.
here?
You gave us more money last year. That was the first year.
Okay, and was that used? Is that?
Yeah.
Okay,
That was the 200 and, that was 287,000.
okay,
So we've fully used that, and we're asking for that. It ran out on the 1st of October, so we're asking for a continuation for next year too.
okay, that's where I misunderstood. Thank you. And then just one more quick question. What about the UBHC? Is that, how is financially, how is that operating? Is that at a break-even point?
That's a great question to know. The UBHC has been a considerable drain on our general fund dollars, and to the point that we're probably projecting a $2 million overrun on general fund for that program. So we've done a lot of redesigning in the year that we've been trying to get it to grow roots. You know, it's interesting that, you know, we have if I can just take a minute to describe it, we have a program that's open 24/7, 365. We market it to everybody, try to get urgent or emergent people into our urgent behavioral health clinic, and we cannot get any traffic or minimal, I mean literally minimal traffic coming through the door in the afternoon and evening hours. Meanwhile, St. John, Henry Ford, and every ER in the county will have 20 to 30 behavioral health people come through their emergency rooms. Some of them get stuck for days this coming weekend, but I can't get them to the urgent care center.
And for the commissioners who don't know or who are new, can you just explain what that is and what the concept is of the UBHC? Because I think that there are some who may not know about it.
So I don't know, maybe you're familiar with the Common Ground over in Oakland County for a long time. They had, what we modeled was an urgent behavioral health care program, and it's right across from the Macomb Intermediate School District. It's open there 24 hours a day. Someone comes in, ambulance, a police, car. They walk in, brought in by a friend. They walk in. We ask them if they have any contraband, drugs, guns, whatever. Lock them up. Here's the key, because we don't check them for that. Just take your stuff and lock it up, but you can't bring it into our facility and come on in. And so then we're, positioned, instead of being in an emergency room where you have doctors and nurses and lots of bright lights. If you're coming in, you're traumatic. If you have a traumatic incident going on, you've got some major depression, some psychosis, you can be met with a psychiatrist, you can be met with nurses, caseworkers, social workers, peers that have also been mentally ill, who, peer support staff. And so the whole paradigm and the whole dynamic is different, whereas you're treated with behavioral health professionals who can do the same or treat you suited to condition comparatively to being in an emergency room. And so and for us to be able to work with multiple consumers, we have a capacity for 12 rooms for adults and 3 rooms for children, isolated in a different section of the building, isolated for children. Then they can come in there. We could help them with, desensitization, whatever their mental illnesses, whatever is going on at that point in time. Provide them maybe with linking, supporting to caseworkers, supports coordinators, their staff, their psychiatrists, their Medicaid card, and then divert them without them having to go to acute psych admission. That was the whole premise behind it. If you go to the emergency room, there's probably a likelihood you have something really serious going on and you're going to get admitted. You don't ever go to an urgent care room thinking you're going to get admitted, I think. And so our purpose was to treat consumers in the community with people who are sensitive to mental health conditions and substance abuse conditions, and to redirect them whenever and wherever possible back to the community without going to acute psych. That was the whole premise.
And the financial premise is that we would be using our Medicaid dollars to the center and not to the emergency rooms, correct?
Right.
So if it's operating at a $2 million loss or a drain, is it your plan to continue to operate it, or are you, I mean, where are you going with it at this point?
Well, we've gone to the Community Mental Health Board and let them know that, for the time being, the evening hours and the midnight hours aren't working. So I think we're down to, it closes at 8 o'clock, 8 or 9 at night, and opens, 8 or 9 in the morning. So it's open about 12 hours a day. And we're do some pre-admission screening, and we're changing a little bit of the design of it. Still takes in walk-in patients and still does urgent care. We're also taking consumers as soon as they're discharged from the hospital, instead of going to, Easter Seals or someplace where they may not get an appointment for 10, 12 days. We bring them right over to the urgent care and do a comprehensive intake and bring them into our system. So we've seen a really big increase in immediate aftercare from acute psych over to our urgent care center. But we have to make it cost neutral. And Cindy can describe it, but if you have 100 people that are coming through, 50 are Medicaid, and 50 are like Blue Cross, Blue Shield, commercial insurance, or indigent, you can take 50% of your dollars and you have to pay for it out of Medicaid. Your other 50% you have to pay out of general fund dollars, or unless we have contracts with Blue Cross, Blue Shield, and every other commercial payer that's out there. We're trying to continually obtain those contracts. I think within time it's still going to expand itself. I don't think it's going to go away. It's just, it's a challenge to be able to market it and bring people through. We've had billboards. Maybe you've seen billboards out there. We have radio advertisements that are out there. We're on Facebook. Every social medium that we can get out there trying to market UBHC. It's just a stickler. We cannot get the traffic to come through there.
So it's no longer a 24/7, 365 operation?
No, I believe on October 1st, it went from about 9 to 9, 9 in the morning till 9 at night, right about that time.
Okay, thank you.
Yeah, sure.
That's disappointing, thank you.
Yeah, I know.
Commissioner Chairman Smith.
Thank you, Chair. Thanks, John. You kind of answered the questions I was going to ask that Kathy just mentioned. Are we having where do a lot of the patients, obviously they bring them to the hospitals. It must be police and ambulance services. Are we real well connected with them? And are they aware of, I imagine they are. I think I remember you talking about it. Is there a disconnect though? As to them, not wanting to route them to you, or are they just, it seems like that's where a lot of the traffic would come from, especially in the later times and in the middle of the night. What's that? Is there an issue with the public services like that, not knowing or not?
I think some of it is, we've done a diligent effort on our end, to train first responders and get out to the local police departments, and to get them to become familiar with our program, to give them brochures, to invite them in on the tours, the openings when we have them. And, I think it's going to be more a matter of their policies relative to how they want to make sure that they, follow proper protocol based on their employment agencies. So if MedStar says, look, you have somebody with some type of acute crisis and, there's any medical, complication, they may have to go straight to an ED. We can't medically clear somebody. That's one of the challenges. We can't medically clear somebody. Sheriff Department doesn't use it. We know that. I don't mean to say that out loud again, but the sheriff.
That's what we're interested in, is finding out who's using it, who's not, and maybe being able to ask them why. And then when you talk about clearing medically, what about when they clear medically through the hospital? Are you connected with them as the next resource? So, okay, you got to leave. We don't have any real medical problems. Here's where you should go.
Yep. We do have that connection. Matter of fact, we have a staff person at Henry Ford on 19 Mile Road that actually works for us and works with Henry Ford, but they're our employee. We've implanted that person, per se, into Henry Ford, and we do bus them, or even if we have to put them in an ambulance, which is expensive, that's borne to the consumer, those costs, but to come from the emergency room once they're medically cleared back to our urgent care center.
Seems like a problem we have in this county, and probably every county, with great services that we provide and offer, but the lack of being able to connect that to the end consumer. And it's just, whether it's veterans or senior services or this, it's just a problem that I know everybody's working hard at it, but sooner or later we got to figure this out, because we offer too many great services in this county that are, just right by people that need them the most. So I appreciate you guys trying this good effort.
Thank you. Any other comments or questions? Seeing and hearing none, we have a motion to receive and file. Please vote.
Thank you.
I was sure we had one. Yeah, I think Commissioner Kraft made a motion and Commissioner Drollet supported it. As opposed to Commissioner Romano.